Welcome everybody, and thanks for joining us for Talking Point today, where we'll be hearing about an incredibly impressive programme of work by Dr. Jessie Young from Melbourne University on reducing drug-related harms and improving mental health among people released from incarceration and presenting a case for continuity of care. Before we get started, I'd like to acknowledge the traditional owners of the land that we're on, recognising that as we come together virtually, for many of us here in Melbourne, that's the land of the Wurundjeri people of the Kulin Nation, and to pay respect to the elders past, present and emerging. So we have Dr. Jessie Young today. He's an NHMRC Emerging Leadership Fellow in the School of Population Health and Global Health at the University of Melbourne, specialising in psychiatric epidemiology and data linkage methodology. He also has adjunct positions at the Murdoch Children's Research Institute, the University of Western Australia and Curtin University. He's authored a book chapter, federal reports and 52 peer-reviewed papers. He's a member of the AIHW National Prisoner Health Information Committee and Technical Expert Group, guiding the world-leading surveillance systems for the health of justice-involved adults. His research has informed national and international guidelines for the treatment of substance use disorders, overdose prevention, and accessing health services for people released from prison. So please join me in welcoming Jessie.
All right, and welcome everybody. I'd also like to acknowledge the traditional owners of the lands that we meet on here today and pay my respects to their elders past, present and emerging. That's particularly pertinent considering we're talking about the criminal justice system and the fact that Indigenous Australians are substantially overrepresented in this system, and it has been an intractable issue. So what I'm going to do today is basically go through some of the research that I've been involved in looking at drug-related harms and improving mental health among people released from incarceration. Just briefly, disclosures. So apart from the funding you see there, I have no actual or potential conflict of interest in relation to this presentation. So I'm going to take you back to 2013, and this is kind of what really kicked it all off for myself in terms of thinking about this area in a different way. And this is a study in the American Journal of Public Health where DiPietro and Klingenmeyer propose that, quote, providers and administrators in both the criminal justice system and the community not only share a common set of patients, they also share important public health goals. And this is one of the first times I'd read in the peer-reviewed literature this idea of kind of multi-sectoral, multi-agency care for people who churn through the criminal justice system. And that really got me thinking, and it's shaped a lot of the research that I've done in this field. So let's set the scene here. So people in prison in Australia, as you can see there, it's been consistently rising, both in the imprisonment rate and the number of actual people at any one day in prison. So that's the cross-sectional average. And currently the average daily number, or best guess at it, stands at over 41,000. And until COVID, COVID has resulted in some rapid policy change and early release for some individuals. It was growing rapidly. So prior to COVID, it was increasing by 5% annually and approximately 25% in the past 5 years. Concerningly and interestingly, annual increase of females in prison is twice that of males during that period. So the female prison population is growing at twice the rate of males. Still only accounts for 8% of the total prison population, but that's concerning nonetheless. Strikingly, until April 16th, the actual throughput or flow or churn, meaning the number of individuals, the number of admissions to and releases from prison was actually unknown or not published. In 2016, in April, the ABS started reporting on those data. In 2017, it was estimated there's 63,000 releases, and then you can see in 2018 and 19 that's risen. That's considerably more than the average daily number, and I'll get to that in a moment. Best estimate of the exposure to incarceration among Australian adults is about 385,000, or 2.5% of the adult Australian population. So this is not a niche area. This has considerable impact on our communities. The real recurrent expenditure on Australian prisons is over $4 billion per year. That excludes healthcare costs in most jurisdictions. The daily cost per adult in prison exceeds the daily average wage by a factor of 2. It's incredibly expensive. And as I stated before, this is perhaps the most concerning slide I will present today. Indigenous Australians are overrepresented in prison by an age-adjusted factor of 13. They're overrepresented by an age-adjusted factor of 25 in the youth justice system. There's a 50% increase in that inequality since 2001. And as you can see on the right there, the disparity is striking and is not good enough. Now, let's go back to the basics. So what's the daily average number versus the prison throughput? Well, the daily average number, as I stated before, is an average of the muster, a cross-sectional average over a number of days. Prison throughput is basically exposure to incarceration, which means it's the number of admissions and or releases. So it shows how much time people are exposed to that environment. And it also shows the churn or the throughput. So in Australia, when you look at the difference between the daily average number and prison throughput, overall, prison throughput is 55% higher than if we just go by the daily average number, and that has implications for resourcing transitions to and from this system. Now, if we do the right thing and actually resource at that 55% increased number, we're actually in further trouble because, as you can see there, males churn at a lower rate than females. Females churn at a considerably higher rate. So if we resource at that 55% level, given that females churn at 176% higher than their daily average, we're going to be systematically disadvantaging females when they transition from the system to the community. For other characteristics, strikingly, it's unknown. So you could imagine looking at, say, substance use disorders. We actually don't know what the throughput is for people who experience substance use disorders in contact with the criminal justice system. WHO has been a leader in this field and have really not pulled any punches in a lot of their reports. Here's one from 2018, the Trenchant Statement on Prisons and Mental Health. I'm paraphrasing here, but they literally say, without the integration of community care facilities, continuity of care, and alternatives to prison, quote, attempts to provide good health care in prisons, and especially good mental health care, will almost certainly fail. Now, this is an acknowledgement that the forensic system and the community system must interact to actually improve the health of people who churn through this system. So what do we know about the prevalence of mental health disorders in the prison system? Well, I'm not going to go through all these statistics on this slide, but as you can see across the board, whether it be dual diagnosis or substance use disorder, mental illness, intellectual disability, I could go on and on. They're all 3 to 10 to 11 times higher compared to the general population. So they're overrepresented among people in the criminal justice system. Another thing that my work has really indicated, and this is actually one led by Kate Van Doren, looked at young people, young adults in the prison system. And what we know here is that complex health needs are normative among this population, whereas they're the exception in the general community. You can see there in the blue, that's mental illness and or self-harm risk. In the orange there, that's a chronic physical condition in the past year. And in the green there, that's injecting drug use. And as you can see that we found that 1/4 of young adults, so under the age of 25, between 18 and 25, had all three of these conditions leading up to release. We could take another lens at complexity, which is multimorbidity, and it's also normative in this population. And you can see there, this is work by Stephen Dent, done a couple of years ago, and he quantified, multimorbidity over 14 domains, and found that the rates across the board were much exceeded what we would expect in the general population. The one good news story is that in Australia, health often improves in prison. This isn't the case in all jurisdictions around the globe, but in Australia we do quite a good job responding to the health needs of people while they're in prison. So you can see here, this is from the AIHW, Health of Prisoners, Australia Prisoners Report. 85 and 86% of dischargees reported that their mental health and physical health improved or stay the same during their prison stay, respectively. Unfortunately, despite any health gains we managed to achieve in prison, without sustained care and support after release, the net effect of incarceration is health depleting. On the right there, you can see this is mortality after release from prison. And you can see immediately in 1 to 2 weeks after release, you have a spike in preventable mortality. And that's the starkest indicator of poor health. We've replicated this, that was from America. We've replicated this in Australia and other jurisdictions. As you can see, what we consistently find is that within, a week or a day of release from prison, you have this spike in preventable mortality, particularly from overdose and suicide. The other thing we found, and this is a study led by Simon Forsyth and Stuart Kinner, is that not all subgroups are the same. So this is mortality after release, and you can see this is for Indigenous and non-Indigenous people, and it's also separated by alcohol-related and drug-related. And what you can see there is that the subgroups differ greatly in how this preventable mortality presents itself in a time-dependent fashion after release from prison. What this would suggest is that we need to get very sophisticated about how we respond to this for different subgroups of of people released and for different characteristics. Here's work that I'm leading in a cohort of 51,000 young people released from youth detention in Queensland. And we see similar subgroup differences. This is overdose deaths after release from youth detention. The other thing is that this is work done by a master's student of mine, Claire Keane. It's not all about death and it's not all about opioids. This is non-fatal overdose after release from prison. And as you can see there in the kind of hashed lighter blue color, that would be non-fatal overdose due to opioids. And if you look at the bottom of the screen there, that's about 2.5 years of follow-up after release from prison. You can see that non-fatal overdoses characterized by substances other than opioids exceeds those from opioids in this study. And you can see again here that plays out in a time-dependent fashion. So this has real implications for how we ascertain that particular outcome and then how we respond to it. Here from the same study is the predictors of non-fatal overdose after release from prison. And as you can see there, that dual diagnosis or a concurrent substance use disorder and mental illness is a very strong and consistent predictor of non-fatal overdose. Here's another study by Claire Keane that I was involved in, and what this shows is that the way we actually measure or ascertain non-fatal overdose is really important. So what Claire did here is she looked at, we combined administrative records with survey data where we asked individuals to self-report if they had ever had a history of non-fatal overdose. And then we looked back in administrative hospital, ED, and ambulance records and ascertained whether they had an administrative record of non-fatal overdose. And what we have here is we basically created 4 mutually exclusive groups. In the yellow there is the true positive. What that means is basically somebody self-reported that they had a history of non-fatal overdose, and that we could see that in the administrative records that they had presented to services for non-fatal overdose. The false negative is people who said, no, I don't have any history, but we could actually ascertain through administrative records that they did have a history of non-fatal overdose. Unconfirmed positive is people who said, yes, I do have a history. However, we couldn't find any record of them seeking care for that. And the unconfirmed negative is basically people who said, no, I don't have a history, and there was no record in the administrative records. What you see here on this graph is when we take those 4 groups and then after release from incarceration, we follow them up and look at how many people in these 4 groups actually do have a non-fatal overdose after release from prison. And 2 things to note here is that people who had an administrative record for non-fatal overdose were more likely, so that's the false negative and the true positive. And you can see there that the false negative individuals had a very high rate of non-fatal overdose after release from prison, similar to those in the true positive group. So if we don't actually triangulate data sources, we're going to miss quite a substantial part of the future burden and that opportunity to prevent those poor outcomes. Here's some work by Beck Winter, who looked at basically people with a history of injecting drug use prior to incarceration, and then basically we followed them up after release from prison and looked at the proportion of individuals who resumed injecting drug use after release from prison. And the take-home message here is that for a substantial proportion of individuals, prison is only a brief interruption to harmful use. And kind of counterintuitively, this study found that people released from short sentences were at highest risk of resumption. So simply responding to substance use in the prison setting is likely not sufficient to provide long-term gains in this area. Here's a study that I led, which basically looks at non-fatal injury after release from prison. And what we did here is basically ascertain 4 mutually exclusive groups, those with a dual diagnosis of mental illness and substance use disorder, individuals who had evidence of a mental illness disorder alone, individuals who had substance use disorder alone, and the comparison group was no mental disorder. And as you can see there, again, there's subgroup differences in non-fatal injury rates after release from prison, and that plays out in a time-dependent fashion. There's an outlier there in the first 30 days, and that rather purple group is the dual diagnosis group. In fact, they accounted for 8 out of 10 non-fatal injuries during the first 30 days. So that's a real opportunity to target scarce resources to try and prevent that outcome during that time period. The other thing that kind of dominates this literature is whether those injuries are due to drug-related causes or whether they're due to all other injuries. So on the right there, you can see that we modeled out those 2 different causes. And as you can see, that spike in the left graph is primarily due to drug-related injury, likely due to tolerance issues and other things. But this gives us a clear target, again, for prevention. The other striking thing is that when you model it out in that fashion, injuries from all other causes actually account for 9 out of 10 non-fatal injuries in this group over time. And so while there's a lot of literature around preventing drug-related injury and deaths, far fewer studies have focused on how do we prevent injury from all other causes. And that's important because it's 9 out of 10 of these events after release from prison. I'm sure that everybody can notice the outlier on this graph. That is self-harm after release from prison, and that is the dual diagnosis group. Now, perhaps a clear target for the 6th National Mental Health and Suicide Prevention Plan would be dual diagnosis among people released from prison. Given that dual diagnosis accounts for 1/4 of individuals released from prison, and also the churn is likely in the order of 16,000 to 20,000 individuals released per year in Australia. So that's a key target for self-harm prevention. Then we did a follow-up study, which I led, looking at, okay, we know that self-harm is, the burden is high among these individuals. What are the rates of receiving guideline concordant aftercare? Meaning, if individuals present to acute care for self-harm, upon being discharged, are we getting them to community mental health care in a timely fashion, which is recommended in the NICE guidelines in the UK and many other guidelines. So what we did here is we looked at time since discharge for people with a history of incarceration who presented to acute care for self-harm. And as that line goes down, more people are accessing community mental health care. Well, the guidelines state that we should get 100% of these individuals to community mental health care within 7 days. And as you can see, there's a little dotted line there at 7 days, and we're achieving about half that. So there's about 50% or just over 50% get to that care. And then we gave it the benefit of the doubt and said, let's model it out over time and look at 30 days. In 30 days, you get about 60%. And then essentially the take-home message here is if they don't go early, they don't tend to go. Strikingly, when we looked at the predictors of that mental health contact and that guideline concordant care, we found that despite being at double the risk of subsequent suicide, those with dual diagnosis substance use disorder were about half as likely as those with no mental disorder to get to that care. Here's another study led by Catherine Snow that I was involved in. What we know is that the health system expenditure by this group is quite high. So among people released from prison, we found that in a year time, 1,307 accounted for $6.5 million in healthcare expenditure. And as you can see in the left table there, disproportionately that was incurred in the acute care system. The other striking finding is in the right graph there, you can see the top line there is people with dual diagnosis. And they were almost 4 times more likely to be in the 90th percentile of healthcare expenditure. So we're not responding very well to prevent or respond to the health needs of people with complex mental health presentations, such as dual diagnosis. And here's another graph. This is another study that I looked at. Basically, the presentation, the reasons for presentations among the acute care system, and this was the dark blue is among people released from prison under the age of 25, and then you've got 25 and up in the lighter blue there. And as you can see, injury, which includes overdose, and mental health disorders are the key drivers in this group and account for the largest, the leading amount of hospital bed days and also hours in the ED. The other thing that's become, is kind of emerging in the literature, and there's actually pretty substantive evidence to suggest that there's a relationship between, unmet health needs and return to custody. And here's a study in preparation whereby, again, we're looking at, people with no mental disorder in the blue, people with mental illness only, risky substance use in the green, and then evidence of a dual diagnosis. What you can see there is that substance use and also dual diagnosis predicts return to custody over time. This is accounting for a substantial number of potential confounding factors, and we're working on a propensity score adjustment to further kind of explain away potential confounding. Although we're not claiming this is causal, so this is likely an indicator of complex needs that are not facilitated. Again, just returning to the World Health Organization, here's the Moscow Declaration. This was in 2003, where they stated, penitentiary health must be an integral part of the public health system of any country. It is necessary for both prison and public health to bear equal responsibility for healths in prisons. And again, this is this notion of continuity of care. If we do not coordinate our response between the forensic and community system, we're going to end up with poor outcomes. And as we mentioned previously, among people entering prison, you have higher rates of illicit drug use, and this requires coordination between the forensic AOD system and kind of referral on to the community AOD system. But as you can see in the Health of Australian Prisoners report in 2018, if you look at the referrals, this is among people about to be discharged from prison. You can see the referral rates to alcohol and other drug services is below 10%, and the community mental health service referrals are around 6%, and OST provider referrals are even less. And you can see here that when they enter, we're talking about rates of illicit drug use up and around 60 to 70%, depending on age group. So that's woefully inadequate. The forensic system is not coordinating care with the community system, and vice versa. What we've done here, this is led by Catherine Snow and Megan Carroll, and we've looked at the rates of health service contacts. So we've linked in for 1,307 individuals released from prison. We've linked in numerous administrative data sources, so hospital, ED, ambulance, alcohol and other drug service data, community mental health, etc. What you can see here is that overwhelmingly these individuals are accessing primary care. And if you look at the teal blue bit of the bar, that's alcohol and other drug service access. Again, I would suggest that's woefully inadequate. The other thing, and this again is a study led by Megan Carroll, We know that as time goes by, contact with multiple service systems by this population, given their complex and multiple needs, is normative. So in the first 4 weeks, you can see that many individuals had not contacted a single service system, and by 2 years post-release, 52% were involved in 3 or more distinct service systems. So again, when we're talking about not only continuity of care, but once they get into the community, the notion of coordinating care across multiple service systems becomes really important. Here's another study that my unit was involved in. This was led by Emma Thomas. And concerningly, even if we do a good job with getting these individuals to community mental health care in the days after release, what we find is that retention in these services is woeful. So you can see here, these 2 groups on this graph are basically individuals who just prior to release were administered the K10, which looks at psychological distress. And you can see we ascertained basically 2 groups, those who had kind of a high declining pattern after release from prison, and those who had a very sustained, very high pattern of psychological distress. Over on the left, so in the first quarter following release, even the very high psychological distress group, only 1/3 of them accessed community mental health services. That was lower amongst the high declining. And by quarter 2, that had reduced, retention in those services had reduced by 2/3 and was under 10% of the total population still retained in those services. Here's a study that I led a few years ago now, which was looking at early primary care contact. So I mentioned in that other graph that overwhelmingly, people were accessing primary care. And what this added to that is basically that early primary care contact is critical. So that period immediately post-release is really critical to increase health service engagement. And what we found here is that you can see across the board, it increased mental health service utilization, AOD service utilization, hospital service, and also subsequent contact with primary care. And the underlying kind of inference here is that GPs in the community are acting in a kind of informal case management and referral process here, which is one of their primary roles. So the take-home message is we've got to get those individuals released from prison to care and appropriate services immediately. So when we take a step back, I think one of the overriding messages that you can take home from this presentation anyways is that we've got complex needs, but we cannot respond to those needs with a complex service response. And this mess in the right-hand corner here is from the Lord Bradley report in the UK a few years back, where basically they tried to map the service provision model for people released from prison with an intellectual disability. And obviously this is overtly complex. I think we need to strive for more integrated and elegant solutions. And we need to acknowledge that, especially amongst this group, poor user engagement is a failure of the service or system meant to respond to their needs. It is not a failure of the user. Service by definition. The other thing that's very clear from the program of work that I've been involved in is there's a discontinuity in the flow of information. So, the community health sector does not communicate well with the forensic sector upon, intake to that system. A lot of things are duplicated because they have to go, the forensic system has to then go through, an intake procedure of their own, get the person to retell their, health profile and story. And then the same thing happens upon release. The forensic system does not transmit that information to the community health system on the other end. So you have a discontinuity of information. And this even happens as we don't often link multi-sectoral data. That is, we don't link the information generated in the forensic system to that of our community health system on a population level. So we also don't know things like the throughput for certain characteristics. We don't know how those systems interface from a health perspective. And this is a real gap in the area. This plays out on a clinical basis, so timely information is critical for continuity of care at the coalface. Again, this is from the Bradley report, and you can see the quote there, correct decision making for the service user can only take place if the decision maker is in receipt of full information concerning the issue they're supposed to respond. So clinicians are terrific on average at responding to issues they know about. Obviously, they're terrible at responding to issues they don't or not aware about. So we need to get that information to the people who can respond in a timely fashion. And that is critical while people kind of transit through the criminal justice system to the community, to the criminal justice system, to the community. So we know that discontinuity of care pervades because continuity of information is a key prerequisite for continuity of care. And in practice, a lack of systematic screening and identification exists. So this precludes people with mental illness, substance use disorders, cognitive disabilities, dual diagnosis, etc., to access and get services which are commensurate to their needs. Transitional planning is often limited and ad hoc in nature, so I mentioned the people serving short sentences were at higher risk of injecting drug use. Well, they're also often not eligible for transitional services and transitional planning. In fact, that planning is rare, and if release is not planned, then often what happens is a medical discharge summary is either not generated or does not wind up in the hands of medical professionals who can act on it. Often there's no formal referral procedure between correctional and health providers, so in-reach is scarce. And on the forensic side, there's often little knowledge of which community services provide which care. So how do we resolve this? Well, it's going to be challenging, but we need to have a concerted effort to increase the continuity of care and information. And despite Australia's no wrong door policy, there's still limited integrated care in this country for people who experience dual diagnosis. We cannot expect a person with complex needs to navigate a complex system, nor can we expect health professionals to act on information they don't have. Service integration and sharing information is critical for success. So whether that be between AOD services and community mental health services, or the forensic services to the community services, you could draw the line through acute to secondary to tertiary care. We need to do better in this area, especially responding to those with complex needs. I would suggest that given these challenges, there's a clear case to remove the exclusion from Medicare, PBS, and the NDS for people in prison. This is a wholly avoidable barrier to continuity of care. And, secondarily, we need to consider, stemming from that, are health services in prison best provided by the Department of Health or the Department of Corrections? In Victoria, it's provided by a business unit of the Department of Corrections. This is a work by Kate McLeod, who basically mapped the authorities responsible for prison health care across the globe. Here's just a little snapshot here. You can see Australia has basically shared or mixed governance across the states and territories. And generally, there's very few countries that provide or have a governance structure for prison health care that's provided by the Ministry of Health. Now, why is that important? Well, potentially providing care by the very ministry that is responsible for that care in the community would increase continuity of care and continuity of information. It's got extreme face validity. However, what this paper actually showed was that there's a critical lack of evidence. We don't actually have the ability to say definitively if that's a good thing or not. And one of those reasons is because traditionally we don't share information from the correctional system and the community health system. Just like to make it clear, this is not a criticism of correctional or forensic service providers. They do a lot with a little, and to correct and respond to complex needs of individuals who churn through that system at a very rapid rate is an impossible task for one department. This is a whole of government problem requiring a whole of government solution. It requires a collaborative effort to share knowledge and avoid duplicating effort. There's so much duplication of effort if we don't share information. That can be interdepartment, interstate, or internationally. That argument we articulated in a recent publication around how prisons in custodial settings are crucial to a comprehensive response to COVID-19. And we published that with representatives from the WHO. And I won't go through everything on the panel there, but I mean, these are things that I've been talking about: joint planning, treatment, information sharing. It's all in there. Just like to end with coming back to the starkest indicator of health. There's a cost of inaction in this area, and the cost is premature death. We've seen this graph previously. People die in rapid succession after release from prison, and high numbers of them. If we do not act in this area, people will lose their lives unnecessarily. This extends to overdose. This is a study conducted by Nasrati and Michael Marmot, where they looked at U.S. counties with a high versus low incarceration rate. And when you went from a low incarceration rate county to a high one, they found there was a 53% increase in population-level overdose deaths. And strikingly, the rate of incarceration combined with household income accounted for 97% of those county or regional variation in overdose deaths at a population level. So the cost of inaction, if we're talking about overdose deaths, is profound. I'd just like to, again, end with a quote from Michael Marmot, who's been one of the leaders in this area for years. Quote, "The causes of excess morbidity and mortality in socially excluded populations, which includes people with a history of incarceration, are not so much different from the causes of health inequalities more generally, but differ in their degree. The challenge is to bring socially excluded populations in from the cold, literally and metaphorically, and to provide them with the opportunity to be a part of a diverse and flourishing society." And when we, just coming back to what Dan Loveman was saying earlier, when we think about or rethink addiction, please consider the voice of individuals with a history of incarceration. It's fundamentally critical to responding to addiction in our communities. And I hope that you sign up to this important campaign and advocate for better coordination of care for people who are transmitting from the prison system into the community, particularly from an alcohol and other drug service perspective. Thank you very much.
Wow. Thank you, Jesse. That was incredible. Such compelling, but also such an alarming, the statistics are really, really frightening. And it's such an incredible body of such high quality evidence as well. There's a lot that we need to do. Some of the questions that have come through on the chat box. I'm going to leave the sort of more philosophical ones to the end, see how we go for time. So certainly some of the ones that I had. Are you happy for me to just go through what I've come out with? So the first one was around the numbers that you presented in the first few slides. Did those figures include, they were on the prison numbers, did they include refugees, asylum seekers and those illegally detained in prisons?
That's a great question. No, they did not. So that was simply people incarcerated for basically crimes. They didn't include those groups, but just noting that those are very, very important groups to understand and respond to the health of, because they are kind of detained in closed settings and have similar high rates of health issues, to my knowledge.
Thank you. And there was a question around the sort of level of educational training that people get with regards to strategies, I think, for reducing harm, both in prison but also post-release. Do you know what's provided by prisons currently?
Is that training to people meant to respond to these issues, or training?
I think for the prisoners themselves, in terms of maintain, safe use and perhaps risk of overdose post-release.
Yeah, so maybe I'll, just because I'm unclear on what the meaning of that question was, I'll answer from two perspectives. So for the first perspective, there are vast differences. So when we talk about training that people, prison authorities provide, there are vast differences internationally. One example is in Norway. To become a correctional officer, it takes 2 to 3 years of basically college or university level training to become a correctional officer, and they have whole modules on health, welfare, etc. in that training. So it's not just safety and security, and I realize it's not limited to that in many other jurisdictions, including Australia, but I think our training programs are around 12 weeks or maybe 24 weeks, so vast differences there. From a perspective of what is provided to individuals in prison, I have to say prison programs are quite extensive. There's a lot of money poured into that particular area. However, the vast majority operate under a criminogenic risk framework, not a health needs framework. And I think that's a key distinction to be made, and a key, potential target for policy reform in the area. And again, I'd just like to reiterate too, the overwhelming evidence suggests that what we do behind the bars is important. However, if we do not kind of continue and provide continuous care at a similar level in the community, then it's all for naught.
Mm. Yeah, really good point. So some discussion around the extent to which there's pharmacotherapy-based programs in prisons, and that there's often a wait list, particularly for those in remand, of maybe up to 6 weeks. Could that account for the high rates of overdose that we're seeing in that initial 30 days?
Well, again, I mean, providing OST in prisons is very important. It's one of the pivotal harm reduction responses that we can provide. The real issue, would it prevent overdose after release from prison? Well, only if it's continued into the community. And again, so that's where it can potentially all fall down, because we know that when people get released from prison, they have a number of competing priorities, and potentially, then rocking up to a place where they feel often stigmatized and not very welcome, to get their OST script may not be the highest priority. So we really need to do better. And some of Emily Wong's work in the United States, where she basically instituted what were termed transitions clinics, whereby a GP with experience prescribing and providing care in the forensic system was paired with what she termed to be a peer navigator or peer community worker who had prior history of incarceration, was quite an innovative model and was found to reduce, costly acute care presentations, et cetera. Considering a similar model might have flow-on effects to OST, et cetera, in the community after release for these individuals.
Fantastic, thanks. I know we're close to time, but I'm going to ask this question because I'm sure it was on a lot of people's minds with what happened or the announcements in Oregon, I think just last week. Is it time to consider decriminalising drug use, given the individual and society benefits that we see overseas? Or for us to at least consider it here in Australia? Good one to end on.
Wow, even the best for last. Listen, I'll be upfront. I think any type of harm minimization policies that will reduce the unnecessary criminalization of vast majority of adults, and particularly targeted at people with histories of entrenched disadvantage and trauma, et cetera, I think is a good thing and will help redress the traditional disparities that we see in our community. And I see, alcohol and other drug issues as a health issue, not a criminal justice issue. And if we can approach it from a health lens, I think that will not only decrease harm, but we'll have a much more equitable and equal society.
Brilliant. Thanks, Jesse. Thank you so much. I'm sure everybody online will agree that was an incredible, amazing presentation and really quite inspirational, and can't thank you enough. Unfortunately, we have to bring it to a close, but thank you all for attending. Just a quick reminder to join the campaign, sign the petition, share it on your social media. And if you've missed the Addicted Australia SBS show up until now, it's on demand. It's available there. And the next 2 episodes will be on the next 2 Tuesdays at 8:30 or 8:35 on SBS. So please make sure you watch it if you can. And please promote the campaign so that we can rethink addiction. Thank you everyone for joining us, and we'll see you probably in 2021 for the next talking point. Thanks.